Dr. Murali, and I'm going to speak to you on the aspect of managing double trouble, which is coexisting cataract with glaucoma, which we very commonly encounter in our practice. I'm going to share my screen now. Very often we encounter cataract with glaucoma in our practices, and it is relatively common uh, in the elderly, of course. And very often we miss the glaucoma because the cataract causes the vision problem, and the glaucoma is silent and relatively asymptomatic in the mild moderate stages, and the field loss and the structural damage is often missed. So we need to do a good evaluation to pick up the extent and severity of the glaucoma underlying the cataract. How do we diagnose? We'll come to that a little bit later. The glaucoma with cataract has surgical options only in terms of cataract. So you can either do an IOL surgery alone and do the glaucoma management later if necessary, surgical or continued medication. You can do a glaucoma surgery first. Suppose you have severe to advanced glaucoma. You can do the cataract IOL surgery later after the glaucoma surgery. You can also have the option of doing a combined cataract and glaucoma surgery. What are the factors that influence decision making in managing cataract with glaucoma? Is the patient's response to medication? Is the patient tolerating the medication well? How many medications are necessary to achieve the so-called target pressure? And the degree and extent of the optic nerve damage and the field loss that is there in that particular patient and eye of the patient. The surgeon's experience and training is also important. Suppose you're a good phaco surgeon, you're capable of doing a phaco trap, or if you're doing SACS trap, you're a good trabeculectomy surgeon, you are good in MIGS and so on. So surgeon's experience and training and each individual eye of the patient and the patient's, say, cost economics. Patient can afford the kind of treatment you're going to offer to the patient. So therefore, all of these factors have to be considered when you decide what to do. And involve the patient as a partner in your management. Do not work in isolation. Do not say decide that this is best for him or her or something like that. Involve the patient, involve the patient's relatives, give them some time to say think over what you have discussed and then plan the treatment. The severity of the glaucoma in the presence of cataract, you have to do a comprehensive eye examination, intraocular pressure, gonioscopy, disc evaluation, visual fields, and imaging whenever media clarity allows you to do OCTs and disc pictures and so on. In the presence of total cataract, look for an RAPD and check for the intraocular pressure. That will be the only clue as to what is happening behind a total cataract. Threshold perimetry, wherever possible, is particularly useful for us to know the underlying glaucoma that lies under the generalized depression of the cataract or refractive error is picked up on threshold perimetry wherever the field test is possible. What about the advantages of doing a cataract surgery, which you're all very comfortable with? Most ophthalmologists would be comfortable doing a cataract surgery. So why not do just a cataract alone and leave the glaucoma part of it to medical management? This is possible and indicated when there's a mild glaucomatous damage in eyes with, say, PAC, primary angle closure, in which there is significant cataract. Target pressure is reached with one or two drugs. The medication is well tolerated. There are no side effects. And what kind of surgery you would do? You can either do a phaco or an SACS and IOL implantation. You would expect the IOP lowering by about 2 to 4 millimeters mercury. And this may not be suitable for lower target IOP in the long term for patients with advanced glaucomas. So cataract surgery alone, IOL surgery alone is not enough. And you may need to continue medication and think of some other options when you have advanced glaucoma. For the mild to moderate glaucomas, you can consider IOL surgery alone. The phaco is a big advantage in glaucoma because the smaller area of surgery, conjunctiva was left untouched with the clear cornea surgery. You can do the surgery well away from an existing bleb. You can also do an IOL surgery under trabeculectomy type scleral flap also. You can do the IOL surgery under that, like a SACS or even a scleral tunnel phaco and so on. IOL surgery advantages, of course, needless to say, the simple surgery doesn't require any special training and permits accurate field tests and optic nerve examination post-operatively. You can monitor the patients well. How is the IOP lowered after just the cataract alone? The angle width and the angle depth increase substantially after IOL implantation. The IOP in eyes with angle closure, open angle, and normal tension also decrease to certain levels. As you can see in the picture on your left, preoperatively and postoperatively, the angle opens up considerably in angle closure glaucoma, and also opens up to a significant extent even in open angle glaucoma. So angle does open up and the pressure does lower with case the cataract surgery alone, but it is not enough to give you a very low target pressure. So what are the problems that you can face when you're doing only cataract surgery in patients with cataract and glaucoma? You can have an IOP spike in the early post-op, and this can damage the optic nerve. So be aware that IOP spike has to be looked for. Small rigid pupils, shallow ACs, floppy iris, weak zonules of fluid exfoliation, and you must be able to handle all of these problems. You must be an excellent cataract surgeon. In subluxated lenses, you must be able to manage the cataract as well as plan the CTR, CT segment, and so on. In very small eyes and very large axial length eyes, myopic eyes, again, you must be able to operate cataract in these kind of eyes. Post-operative CME is said to be relatively somewhat more common than regular CME because of the bag containing previous usage of glaucoma medication. This could be a possibility. So what about glaucoma surgery alone? When you have uncontrolled severe glaucoma on maximum medication, you have patients with uveitis and neovascular glaucoma, very minimal or no cataract. So you can consider IOL's glaucoma surgery alone, trabeclectomy alone. So the vision will remain unchanged and the cataract is likely to progress. That is the downside of doing the glaucoma surgery alone. So once you've done a glaucoma surgery and you probably plan for an IOL surgery after glaucoma surgery, this becomes two procedures, higher cost, more risk of two procedures, surgical skill to avoid the bleb damage has to be, you have to have more skill for that. And despite everything, whatever you do, the bleb can actually fail after the IOL surgery, resulting in a raised intraocular pressure, the bleb failure and so on. So IOL surgery in eyes with bleb, certain precautions you can follow. Wait for a few months after the glaucoma surgery. Avoid external pressure. Lower the bottle height to prevent bleb rupture in very thin-walled blebs. Leave the bleb untouched and stay away from it. Suture the cataract incision for the phaco. And also, you can use probably some of these newer methods of and newer technologies and machines available, such as the sovereign kind of machines in which you can preset the IOP, make it comfortable for the surgeon and don't spike up the IOP too much, unlike in machines which don't have IOP control. And this is from Uday Devgan's cataractcoach.com, in which there's a lot of information and parameter choosing, choice of fluidics and parameters for each mode. So I think you can go through this as well as to understand that IOP can remain controlled. And this is one of the things which you can do when you have a thin-walled bleb in an advanced glaucoma patient and you're going to do a cataract. You can use these kind of slow and careful settings. Combo surgeries, cataract and glaucoma. And you have cataract with uncontrolled IOP, medication is not tolerated. IOP lowering is definitely better than IOL alone. The visual improvement is better than the trab alone. There are no IOP spikes in the immediate post-op because you already have a filter there. The filtration surgery has been done. And of course, the lower cost of not doing two procedures and the lesser the morbidity because number of visits the patient has to make to and fro is also less. So there are different advantages of the combo surgery, combined surgery. Combined surgery has evolved from the 70s to various methods, relatively primitive methods as to what it looks like primitive now. ICC, ECC, phaco trap, SACS trap. Now we have the endocyclophotocoagulation, you have the NPGS. You can also combine with glaucoma drainage devices, the cataract surgery. And of course, now the MIGS has become very, very popular. So what does the literature tell you about phaco with trap? That the separate site lowers the intraocular pressure more than the same site kind of surgery. The use of antimetaplites is useful. And the choice of IOLs, it's better to avoid the multifocals because of the problems of glare and contrast. EDOF lenses are okay. You can consider torics when you're doing MIGS and so on. But generally, we would avoid multifocals because of the issues related to the contrast and glare which these patients have. So my algorithm for managing cataract with glaucoma is when you have a mild glaucoma, good IOP control with medication, I would probably do an IOL surgery alone, like a phaco. And if you have medication problems, medication intolerance, then I would probably do a combined surgery. If you have moderate to severe glaucoma, I would prefer a combined surgery. I would use an antimetaplate and do the surgery in separate sites. For moderate glaucomas, I would probably consider phaco with MIGS and so on. For the severe glaucoma and you want a lower intraocular pressure, I would either do a MIGS procedure like GAT, consider a GAT kind of procedure, or a trabeclectomy. I'm going to show you a few video clips of how the procedure is done. I think my video is not playing. I'll come back to show you the videos a little later. With regards to what are the available MIGs now, MIGs without implant, you have the GAT procedure, suture GAT, which is now popular and many surgeons are doing it. It is done ab interno using a surgical gonio lens. You need to use a 50 Prolene suture and so on. You also have the trabectome. You also have the Kaazhcha dual blade or the glide, which is available. These are all the ab interno procedures without implant. My favorite actually is to use the Kaazhcha dual blade, or I also use what is called as the Tanito hook. The Tanito micro hook is another efficient, elegant way of doing a goniotomy for about 100 to 120 degrees with the angle using a straight or an angled hook. The Tanito hook works like the Kaazhcha dual blade. You also have the MIGs with the implants. I think one of the other speakers in this meeting would talk to you about the different aspects of GAT and MIGs and so on. This is the eye stent inject, in which two eye stent implants have been placed in the angle to assist with the outflow of the procedure. So I would like to stop my share here and thank the organizers for allowing me to speak in this meeting. And I would share my videos of the procedure in a separate presentation. I'll see if I can send it across to you.
Good afternoon, sir. Are you? Can you hear me?
Yeah, hi, Dr. Murali.
Yeah, I think now we have done a single site procedure.
Pardon me?
Single site procedure. You usually go for the single site procedure or dual site?
No, actually, my preference is to do a separate site most of the time.
Okay.
Initially, I used to do the scleral tunnel kind of surgeries when you're doing SACS trab, and nowadays it's almost always separate site and clay cornea phaco with the standard kind of trabeculectomy.
Okay, sir. Okay.
And very often with the mild to moderate glaucomas with significant cataract, we have now completely switched to phaco with MIGS. So the trab we reserve only for the advanced glaucomas. Most of the time it is phaco with MIGS, either with the Kaazhcha dual blade or the Tanito micro hook. So very rarely I do GAT. I'm not a big proponent of the GAT, but my favorite is to do the KDB blade.
Okay, sir.
How much reduction of IOP do you get with
With the phaco MIGS, you'd probably expect about 25 to 30% and IOP lowering. And the IOP seems to work consistently low over the next 2 to 3 years at least.
Okay, sir. Thank you very much for both your talks. Good day to you.